Hi, everyone, and welcome to our April edition of Hot Topics, the Acute Pain and Regional Anesthesia edition. As always, I am the host and moderator today, Jaime Baratta, from Thomas Jefferson University in Philadelphia. And today we have a really fun panel and a fantastic panel of speakers. And they'll be talking about a topic that we don't always talk about as much or haven't talked about recently, sonoanatomy of the spine. Now, our first speaker is Dr. Vivian Ip, who is an associate clinical professor of anesthesia at the University of Alberta. And she is the director of the Ambulatory Regional Anesthesia Program and the director of Regional Anesthesia and Acute Pain Medicine. And she is also currently the vice chair and editor of the ASRA newsletter committee. And she will be speaking on the sonoanatomy of the non-obese and obese spine. Our second speaker will be Dr. Sharon Peacock, who is an assistant professor at the University of Toronto. Her clinical interests include regional anesthesia, POCUS, and medical education, and she has vast experience in neuraxial ultrasound. And she'll be speaking on neuraxial ultrasound of the difficult spine. And last will be Dr. Sanjib Adhikary, who is a professor of anesthesiology at Penn State Health, and he is the chief of regional anesthesia and acute pain medicine. Is a very active faculty member at a number of ASRA events, and I'm sure you've seen him, as well as a very active researcher, and published a lot of articles on paravertebral and erector spinae plane blocks. And he will be speaking on actually his tips and tricks for paravertebral blocks tonight. Now, if you have any questions, please type your question into the small Q&A box at the bottom. And when finished, don't forget to click send. You can also be looking at the chat box if you have anything to say there. We'll have a nice Q&A session at the end to address any of your questions. If we don't get to a question, you can always reach out to us on the Hot Topics ASRA webpage, or on you can reach me on Twitter as well. So I look forward to hearing your questions. I'm going to let Dr. Ip take over as the first speaker. Thank you.
Thank you very much, Jaime. Slideshow. So my name is Vivian Ip, and my topic today is how I do it, ultrasound scan of the spine, lean versus the obese. So I'm from Alberta in Edmonton, Canada. This was taken a few weeks back. In fact, we had snow last night. So it is a very cold place, and we have long winters, but it can be very pretty. I have no conflict of interest, and here are the objectives of my talk. So basically, by the end of today, or by the end of my talk, you'll be able to have a systematic process to ultrasound scan the thoracic and the lumbar spine in both the lean and the obese. And here's the outline of my talk. So let's jump straight to the anatomy of the lumbar vertebra. So to understand the ultrasound image, you need to know several bony landmarks, really. So this is the spinous process, the lamina, the articular process, and the transverse process. And the transverse process is anterior to the articular process, unlike in the thoracic vertebra, where the transverse process is posterior to the articular process. That means the transverse process is more superficial on the ultrasound image. And here, the spinous process is elongated and slanted down, and they may overlap between the 5th to the 8th vertebra as well, meaning that it can be difficult to get an ultrasound window. So what do you do to scan the lumbar spine? Well, first of all, you want to position the patient well. So ideally in a sitting position with a back curved. And you would use a low frequency transducer probe so you get a better penetration. And then these are the two probe orientation that I like using, the paramedian sagittal and the transverse. So the paramedian sagittal, first of all, I will place the probe just off the midline and rotate it towards the midline. So in essence, I am looking in between the lamina. And I would put my probe a little bit lower down in the back and scanning over the sacrum. Why? Because sacrum is a long, flat bone, and I can see the hypoechoic line and the acoustic shadowing underneath it. And just the level above, we'll get the lamina of L5. And the interspace between L5 and S1 is usually the largest. So more often than not, you'll see the at the anterior complex, which is made up of the posterior longitudinal ligament and the vertebral body. And so go ahead and put this interspace in the middle of the image and use your marker to put a horizontal line against the long side of the probe. Here you have the L5S1 level. And go ahead and do the same to other levels as you're scanning more carefully. And between the lamina, you can also see the posterior complex, which is made up of the ligamentum flavum and the dura. And here you can also measure the depth to the posterior complex. So as you scan more laterally, you'll see these continuous humps, which are the articular process. And more laterally still, you'll see these transverse processes, which cast a bony shadow here, a bony hypoechoic line, and a thin, long acoustic shadow. And in between, you'll see the psoas muscle, and you may even see the lumbar plexus. So go ahead and turn your transducer 90 degrees to get the transverse spinous process view as you scan over the spinous process. And here, the bony landmark is important because it shows you where the midline is. So here you can see the spinous process, and on either side of it is the acoustic shadow cast by the lamina. So go ahead and mark the midline by putting a vertical line against the long side of the probe. Now, if you scan in between the spinous process, you get the transverse interspinous view, which shows you the soft tissue, the interspinous ligament, the posterior complex. And if the neuraxial space is good, then you can even see the anterior complex. So this will be a good space for your neuraxial block. You can also measure the depth to the posterior complex using this view. Now, moving on to the thoracic spine. Basically, the positioning, the choice of probe, and the probe orientation are the same as the lumbar spine, except to say that because the spaces in between the lamina are small, there may be limited paramedian sagittal oblique laminar view. And also, thanks to the steeply slanting spinous process, the transverse interspinous view may also be difficult. So, firstly, you do the paramedian sagittal view, and I like to scan the most the lateral, from the lateral to the medial, because laterally over the ribs, you get the distinct round hypoechoic line, and with the acoustic shadow and the pleura in between. And as you scan more medially, you'll see the transverse process. Here you'll see the change in shape, more rectangular shape. And let me use a video to show you of scanning from the medial, from the lateral to the medial onto the transverse process. You can see the change in shape. And scan more medially still, and rotate your probe towards the midline. You'll get the paramedian sagittal oblique laminar view. Here, the lamina is flatter compared to that in the lumbar spine. And in between the lamina, you may see the posterior complex as well. So now go ahead and turn your probe 90 degrees to get your transverse interspinous view and try to get in between the spinous process. Here you'll see the midline. And also this view would be good for you to do the paravertebral block, which you'll hear more about later on in this webinar. And you can, now how can you use the ultrasound to help managing the obese patients? Well, usually the landmark is very difficult to palpate in the obese. You have no idea where midline is. You can't feel the iliac crest, and you have absolutely no clue where which spine levels you're at. So ultrasound can help that. And it can also help estimating the depth of the posterior complex. So it helps you to choose the correct length needle to use. And as I say, if you can see the anterior complex, which sometimes you can, then you know that that's the great space to try to perform your neuraxial block. What does the data show? Well, this group in Alabama has recently published the randomized control trial showing that the epidural placement time is much less in the ultrasound group in these severely obese parturients. And it is more marked in junior residents. And the number of needle passes is also significantly less in the ultrasound group. So similar finding is shown earlier on in the Toronto group, where they found the first attempt success rate was twice as high in the ultrasound group. And similar findings in the Turkish group, although surprisingly, the spinal block time was similar between the ultrasound and the landmark group. So using ultrasound, even the paramedian view to estimate the depth actually correlates well with the actual midline needle insertion depth, as shown here in this Western Canadian study. But of course, ultrasound tends to underestimate because you do have to apply more pressure when scanning the obese. Similar finding in the Eastern Canadian group. And they also found that using the paramedian sagittal oblique view and the transverse median view are actually similar in estimating the depth. So why is it so difficult in using ultrasound in obese patients? Well, because ultrasound beam's attenuation increases with fat thickness. It also increases with ultrasound frequency. So that's why you use a low frequency probe. You get the penetration, however, you do lose resolution. And positioning these patients can be difficult. So what are the tips and tricks? Well, first of all, your ultrasound setting. You make sure you have deep enough view, increase the gain, and go ahead and turn on the penetrate mode. And if you have focal points on your ultrasound machine, put it to the area where you're most interested in. Some advanced ultrasound machine actually has tissue harmonics, so turn it on. And use the low frequency transducer. And again, you have to apply more pressure when scanning the obese and also enough gel. And don't expect, a great quality image, as I'll show you later on. But use your bony structures like the sacrum and spinous process to help you. And remember, the L5-S1 interspace is your best friend. So let's have a look at some ultrasound images between the lean versus the obese. So here's the transverse spinous process view of the lumbar spine. And on the right, you have a patient with a BMI of 58. On the left, you have a lean patient. So as you can see on the right side, the image quality is much worse, but don't let that scare you. Have a look and see there's actually symmetry in this image, and that you can even see the hypoechoic line. That's the bony structure. So what is it? It's the lamina. And there you have the spinous process. So there you have the midline. And how about the transverse interspinous view? Well, you can see the soft tissue, but you're not too sure what it is. But here we go. You get the you can see the anterior complex here. And how about the paramedian sagittal oblique lamina view? So scan over the sacrum, get your line mark. So this hypoechoic line is the sacrum, and just the space above that, you can see the anterior complex. And have a look at this paramedian sagittal transverse process view. Of course, you're not going to expect to see your lumbar plexus and in between the transverse process, but nonetheless, you can see the hypoechoic line from the transverse process and the acoustic shadow caused by that. So in conclusion then, yes, there is some pattern recognition, but knowing the anatomy is essential. Use a systematic approach. And the data is supportive of using the ultrasound scan in the obese patients. And don't forget to use your bony landmark because they can guide you. Thank you.
Sharon, you're muted.
Okay, there we go. Thank you guys so much for this opportunity. I am Dr. Sharon Peacock. I'm one of the Regional Anesthesia Fellowship Director at Sinai Health, Mount Sinai Hospital in Toronto. And I also work at Women's College, where we do a lot of ambulatory surgery and lots of regional for that reason, to be able to facilitate patients going home. And today I've been asked to talk to you about the secrets of my success. Neuraxial and the difficult spine. So I have no disclosures and no conflicts of interest. So to start, predictors of difficult neuraxial. I think we all can appreciate when we walk into the room, when we can recognize this is potentially going to be a hard neuraxial technique. The predictors in the literature include obesity, a previous difficult neuraxial, challenges in terms of identifying the bony landmarks and deformities within the spine, which also then are demonstrated in radiological characteristics, which show abnormalities or non-anatomically standard views of people's spine. So what's the answer? The answer is ultrasound. I had a slide looking at all the literature and all the evidence. It shows ultrasound is more effective in a difficult neuraxial, but instead of boring you, I thought I could give you some practical and clinical tips on how to do that. So as Dr. Ip had mentioned, and I'll very briefly review this, obesity can be a challenge. There's often less penetration of the ultrasound waves, and you need to apply more pressure to get that good view, which is then going to be the identifier that you're going to have a more successful technique. It's important as well to maintain position for these patients because with the increased body mass, small changes in their position might not look like a big change of what they've done, but in terms of the neuraxium, it might have actually changed it quite a lot. So when you've marked everything out, if they start wiggling a little bit, it could actually be a great difference in terms of where you've already marked out your spots. The other challenges with an obese patient is often there's a less crisp loss of resistance. And you can, in fact, sometimes insert the catheter in adipose tissue because it's not as firm. So if you have opened up a space and you're using saline, it's even possible to put the catheter in the non-epidural space, and it might even go easily. The other thing to be cognizant of, as Dr. Ip alluded to and mentioned, is you have to add a lot of pressure when you're actually marking out the anatomy. So what I always tell my residents is once you've marked everything out, you have to let go of the pressure on the probe, and then at that distance to measure the actual depth, remembering that if you're using a long needle, that you're going to need to insert the catheter that much more because the needle is actually longer. In my institution, we often insert the catheter minimum 6 to 8 centimeters in the obese patient. And finally, I always suggest to people, if you're not 100% sure if this catheter is in the right place, to do confirmatory tests, which include the SUI test and waveform analysis to ensure that you are in the space that you actually think you are in. So the other big topic I wanted to discuss was scoliosis, because this can often be very challenging. You might have a skinny patient, and then when you go to put the ultrasound in, you see a rotation of the spine. If you take nothing else from my talk, I would like you to look at this slide. This is the key. You have to understand what is happening in the scoliotic spine. The tendency for what happens is the spinous process is basically a free-floating bone at the end. And when you get a scoliosis, you have a tightness, the concavity, and you have the openness, the convexity. And what happens to the spinous process, it actually moves towards the concavity, which is counterintuitive when you're trying to think it out. The reason for this is because all the muscles in the paraspinals get very tight. And as this free-floating end of the spinous process actually gets pulled towards the concavity, which is the side that's going to be tighter. So this image, this MRI image actually shows really nicely that you actually get a sweeping of the spinous process towards the concave side. What this means is when you're actually inserting the epidural or the neuraxial technique, you need to think about the angle in which you're inserting and where you're actually inserting it. So although your needle might be going completely off direction or you think it's off to the side, it's in fact going towards the midline. In a paramedian approach, you also want to be towards the convexity, which you're going to have more opening up of the space. So in the paramedian, you want to know where the spinous process is, and you want to identify the opposite side, the convex side, which will be increase your chances of success for a successful neuraxial technique. So again, these images just show when you put the ultrasound probe, how the rotation might actually catch you off guard and by surprise. And then when you're marking out with ultrasound, you need to pay attention to the angulation that your probe is taking to get that perfect bat wing, because it's that angulation that's going to be the direction towards the midline if you're doing a midline approach, or that will be the side, the convex side that you want to do your paramedian. And again, this just demonstrates it. So when I actually find that perfect bat wing and I make it symmetrical, I make the transverse process, the facet joints look symmetrical, I get the image on my screen, and then I look at my hand and I look at how the probe is angulated, and I know that that is the direction that I'm going to need to take. In scoliosis, a corrected scoliosis can also be very challenging for being able to successfully execute a neuraxial technique. The surface anatomy is often altered, so you can't rely on what you see at the skin. It's often difficult to position these patients, one, because they might have underlying chronic back issues, but two, because the whole point of this, of the rods, if they're having Harrington rods, is to stabilize the spine, so they may not actually be able to give you much flexion. There's also changes in the deep anatomy of the tissue. Scar tissue can be very rigid and sometimes feel like bone. And you might actually think that you're hitting bone when in fact you're actually hitting the scar. Sometimes the Quincke needle is more effective at being able to pierce through, and you might not be able to actually pierce through with a Whittaker. Moreover, the whole point of scoliosis correction in Harrington rods is to actually have bony formation to stabilize the spine into more neutral position. So this bony overgrowth may actually prohibit you from doing a neuraxial technique, and often it is impossible to do it in the midline, so you need to take a paramedian approach. There also can be disruptions in the ligamentum flavum, so you might not have that, you've done 1,000, you know what you're feeling, you know what you're supposed to be feeling, and then it isn't exactly that. And that's why doing the ultrasound as well is helpful, because it also allows you to get a gauge of the depth so that you're not solely relying on your tactile sensation of what the normal usually feels like. And finally, there might be adhesions in the epidural space. And because of this, you might not have the normal spread. And it depends on what your goal of the anesthetic is. This for analgesia or anesthetic? Because you might not be able to achieve a true surgical block if there are these adhesions that exist, especially in the epidural, when you're doing an epidural. I've included this website. I actually think it's a great website. I watched it when I was trying to figure out how to explain what happens in the surgical correction. It's geared towards children, but it really is a very simplified way of explaining what the changes happen. So this is a corrected scoliosis, and you can see the Harrington rods, and right underneath the Harrington rods, you can actually see what the normal acoustic window is. When Jamie asked me to give this talk, it's interesting, we were just debriefing before this. I actually had a patient with Harrington rods, so I'll show you her images later. So why do blocks fail? In an uncorrected scoliosis, there is a preferential spread towards the concave side because everything is tight. And this is where most of the local anesthetic will want to collect and to give a denser block. Therefore, you might have block asymmetry. This can often be overcome with increasing volumes, especially in an epidural. In corrected scoliosis, there might be adhesions or obliterations of the epidural space, and this actually might interfere with the spread in an epidural. Often we see, and the literature will demonstrate as well, that there's more consistency of a block when you actually get a true intrathecal block for spinals, because you actually see the CSF back. So you know that there's usually a better chance that you're going to have a more reliable block. Why does any of this even matter? So the normal risks that we talk about with patients are actually increased when we look at someone who has abnormalities of the cervical spine. Of the spinal column. There's increased risk of neural injuries, spinal hematoma, post-dural puncture headache, infection. There's also less efficiency in terms of the procedure, and that's why ultrasound actually can make you faster. People think it slows you down, but in these challenging spines, it actually makes it easier because you actually know what you're dealing with anatomically. And also there's increased patient discomfort and dissatisfaction, often because the procedure takes longer and can be more challenging. Moreover, in congenital spines, you have to be very careful. You have to understand what the underlying etiology is, because if there's actual congenital abnormalities from birth, there might not actually be normal formation in the spine, and you actually increase the risk of causing true neural injury. So I work in an institution where we do high risk obstetrics, and we do about 8,000 deliveries a year. We have very difficult, we get all the difficult patients in terms of underlying comorbidities when it relates to their spine. So we routinely do preoperative consults in these patients for multiple reasons. One, so we can review their history, understand the underlying etiology of what their spinal abnormality is, but also so we can set clear expectations for these patients and have a good worked out plan so that when they come for their delivery, there's less chance of surprises, both for the patient and for the team, the medical team caring. We review review the images at these pre-op consults, and we ensure that they're available for the day of when they present to labor and delivery. And we often counsel people on having an early epidural placement so we can actually test the quality of their block. In a corrected scoliosis, we recommend placing the block above or below the site of previous surgery. So some generalizations for ultrasound in the different difficult neuraxial. Ultrasound allows you to see the midline of the spine, so you know exactly where you are. It allows you to mark out the intervertebral level so you can be more predictable at what levels of block you're going to get. And it tells you the angle and the proper needle insertion point to be successful. It also gives you the depth of the epidural space. And remember, in the obese patient, get the good view and then release your pressure so that you can measure the true depth. And finally, it can also tell you if there's going to be any obstructions in the context of the spinal instrumentation. When you're looking at the ultrasound image, you're looking for that perfect bat wing. When you get that perfect bat wing with the anterior complex and everything symmetrical, that's your highest likelihood of success. A good transverse interlaminar view has very good positive predictive value of being successful. So I'm just going to briefly talk about real-time ultrasound. I actually do it. It's a very challenging technique. It's an advanced technique and it takes practice, practice, practice. Don't make the first time that you do this the challenging one that you're trying to successfully execute the block on. Do it on the easy patient so you can get skilled and comfortable using the technique and finding how to find your needle tip so that you are successful when you actually need to execute it. Again, it's an advanced skill, and when you're doing it for epidurals, you usually need two practitioners, one to actually help you, someone who knows what they're doing to find the needle tip, and the other person to handle the needle and to do loss of resistance. Practice, practice, practice. And with this and with any of these procedures, do not persist. We are all anesthetists. We are all capable of a general anesthetic. You need to have a plan. You need to know what your plan is and know when you need to execute plan B. You increase your risk of complications the more you perseverate on trying on this whole. So these are a few cases I wanted to share with you, all which came up after Jaime asked me to present. So it was perfect timing. So this is an obstetric patient. When you look at the dotted line, that's where it looked like her midline was when you just observed her anatomically. The resident went and put the ultrasound on and was like, uh-oh. And then they asked me to come in. So where her true midline is where the solid line is. And I've marked out my levels. So when I put the ultrasound on what I thought was the midline, this is the actual view that I got. So what I then did is I moved I don't even look at what my hand is doing. I just move the view so I get what looks symmetrical. So I get this perfect bat wing. And once I have the perfect bat wing, then I actually mark it. I look at my hand, I look at the angulation of what my probe is, and I just actually mark it out. So you can see there's two kind of angled lines. The top one is actually at the L2, L3, which was less angulated and a better space. So it was that perfect bat wing I just showed you. So that's the space that I chose, and I got it on the first try without any complications. This is a case of Harrington rods, a patient who came in for a planned C-section. What you can see, the top lines, I can't actually show you my mouse, but the top lines in the left picture are actually the Harrington rods, and the bottom bright line is actually where the laminar screws had gone in. And this is a paramedian view in her thoracic spine. This is actually where the thoracic spine and the lumbar spine met. The lumbar spine didn't have any instrumentation. So you can see the end of the rod, the last screw, and then on the right of the screen is actually her lumbar spine, which was normal and didn't have instrumentation, but you can see very challenging views. Nothing looked normal on ultrasound. This is the remember I said if you have a nice transverse interlaminar view, highest chance of success. These were actually her transverse lumbar views, very difficult anatomy. And this is actually her MRI, where you can see that it's the Harrington rods have obscured all the image in terms of her spine. And she actually had a lot of deformities, chronic from her long-term previous surgery. You can actually also see the baby there. And finally, this is an arthroplasty patient for a total hip replacement. When you put the probe on, this was the view that I got. It actually wasn't too bad. So what I did is I just moved it so that I got it as symmetrical as possible. You can see there's a little bit of asymmetry in the facet joints, but this was the most symmetry that I could get with everything seeming midline. And then I look at my hand and it was actually veered towards. So this is the single shot that we did for her. And those are the cases in the presentation on some practical approaches on how to manage difficult neuraxial. The last thing I want to show is this is a really nice article that shows a very stepwise approach for approaching neuraxial in a severely scoliotic patient. And I just like that it kind of lays it out. So it's a nice reference if anyone would like.
Hello, everyone. Good evening. Can you see my screen? Okay. So today, after two excellent lectures, I'm going to talk to you about a small journey of paravertebral block, how it started or how it began and where we are today, with simple tips what we can do to get it better. I'm a professor of anesthesiology at Penn State Hershey, and I've been doing anesthesia for more than 20 years. That's all I should say. I do work with a number of industries, but for this lecture, we are not going to discuss anything likewise. So, in fact, the paravertebral block is a very, very long time old block. It's been there for a long time. In fact, it was done around the same time as epidural. Epidural started around 1904, and this Hugo brought it up in 1905. After that, in fact, Arthur Lowen in 1911 did a catheter technique, and it called paravertebral conduction of anesthesia. It was almost neglected after that, but in 1979, when Eisen and Watt revisited the thoracic paravertebral block and generated the interest again. But I would say till 2001, there was no major article or major things about the paravertebral block. Manoj, who is one of my mentor, and actually he exposed me to the ultrasound in my life for the first time. And he was actually the pioneer in some sort of in thoracic paravertebral block. But he did it completely landmark basis. And we know this technique from the landmark that you go and hit the transverse process, move it up and go. Some people go down or caudal, some people go cephalad, but he described it when going toward the cephalad after hitting the transverse process 3 centimeters from the midline. Interestingly, the indications of the thoracic paravertebral block has not changed from the time he explained it, and till today is the same, and it has been going on. So from 2001, it was slightly been okay, but in 2009, the pure ultrasound guided block, they call PUSG, was adapted or described by this Danish group. You have to give them credit that they described this technique, and they showed some amazing work in that they proved that when it is done, so they approach the paravertebral space in two different ways, as you can say in the transverse and the longitudinal view of the needle. And when they did it with this thick arrow, along that, not in the transverse way, they found that the success rate was much higher, and they could not get into the intervertebral foramen, which is a major risk in paravertebral injections, whereas in the other way, they could get in. So it was after that they did some fantastic work with the catheter. So with the single injections, they had amazing results, and they said that this is the way to go forward, and this is the technique, and this is the approach we should follow. But when they put the catheters through this needle, they found the catheter all over the place. So basically, they said that if you're doing single injection, that's fine, but when you are doing catheters, it could go many different places when you are doing paravertebral block. So from 2009, when they described this, it was there are a lot of research and a lot of different approaches were going on. And 2015, this article was there. If any of you really are interested about the paravertebral block, this is an excellent article, and I would suggest that if it is accessible online as a free, so everybody should follow up this article. So in this, the Paul Bigleson and the Dennis group combined together, they described mainly different approaches and different. So by 2015, so from 2001 to 2009, there was no ultrasound approach, and 2009 the ultrasound guided approach started. By 2015, there are 9 different approaches were described in the literature for the access of thoracic paravertebral. I think this is the major problem or major issues with the thoracic paravertebral block not being popular, because there are so many approaches and so many ways you can get there. But nobody really studied one approach versus the other. It is difficult to study this much, and that is why I think the paravertebral block has become an enigma, or some cases questionable for many people. I specifically mentioned this approach here because I'm going to talk about it later why I specifically this. But if you look at the paravertebral block with the different approaches, as I said, there are 9 different approaches. It described basically depending upon how your ultrasound probe is. There's transverse probe or the longitudinal probe. And there is another special was the oblique probe, right? So in the transverse way, you can go either out of plane or in plane. So the from inside to outside or outside to inside. So there are different ways you can reach the transverse thoracic paravertebral space by looking at the images at the transverse level, or the similar way in the longitudinal probe basis, you can go cephalad or the caudal. So as I said, there are multiple different approaches to reach the same paravertebral space by using ultrasound. And the most modified with the PUSG group or the Danish group, what they used is the oblique approach. And I like this approach. Why? Because it is the success of the going into the paravertebral space is very good. Whereas the danger is the thoracic when you put a catheter. Let's go why, how we do it at Penn State. Actually, it's me. We have number of attendings. Some of them do it in a slightly different way, but I'm just talking about how I like to do it and why I do it. So as my 2 previous speakers spoke to you already, find the midline. You know that this is the midline. Then you know that, okay, this is your transverse process. Then you rotate your probe, see the transverse process at this 3 centimeter lateral. Once we know that transverse process, you are seeing the 3 different levels of transverse process, rotate the probe in an oblique fashion where the lowermost part, the caudal region is towards left and the cephalad is on the front. So you, in this picture, if you see, we are at the transverse process in the middle. One is the rib, one is the lamina. So with this picture, you know that we have to come in and get under this transverse process. So once we mark that, this is actually my resident doing this procedure 3 days back. So we numb up the skin, we get the catheter, we get in there. Then once we get the needle there, once you have administer some amount of hydrodissection, you see your pleura being pushed front, we put the catheters. And we usually use the Peacock ECath because we do not want to go anywhere else. So our needle endpoint is almost the endpoint of the catheter. And that's specifically because of this reason, I like this technique, because we know that we are in the paravertebral space, and after that we are not going forward or going anywhere with our catheter. We just secure this catheter and we're done with that. So as we have discussed that paravertebral block, even though the space is so tiny space, we have gone through so many different approaches and something. What is new right now? Interestingly, last year, this article came out from the Korea, and what they did fantastic CT scanning and really cross-section of the paravertebral space. What they basically demonstrated is, till now, as you know, that the old theory is the ligament, the supracostal transverse ligament and the intercostal membrane was a continuous structure. And every discussion and every approach till now, they suggested that you have to pass this to get into the paravertebral space to get more effective. What they demonstrated in their paper, that in fact this ligament is not as we think so. There is penetration, there is a lateral and medial entry, and there is a much more association of different types of nerves with this region. So maybe this actually bring it to our discussion that maybe the ITP block and ESP block, why they are acting or why they are working, has some relevance to this anatomy. We still have much to learn from this, but I personally feel that this has changed how we think this is going to be. They also said in this that there is quite tight artery and venous system. So even though we are safe in putting a catheter into that, we should be aware that there is chances of bleeding and hematoma. So as we can say that we might be more protected remaining superficial to the exact going into the paravertebral space, but it can work paravertebral. If you go into paravertebral space, you have to be careful about what you are getting in. This is the correlation of their anatomy to the ultrasound image. So it demonstrates to some extent that, in fact, we really do not have to go into the paravertebral space or behind the transverse process as we thought to be. In fact, the intertransverse process itself may be working as a paravertebral space, thoracic paravertebral block if we are done sometimes. So there is more question to this, to the answers right now, but I think thoracic paravertebral is going to come back, and it has its own indication in particular relevant cases. Thank you, everyone.
All right, thank you to all our speakers. That was great. I love those talks and they're really interesting. I know we have a lot of great talks or great questions out there. So we're going to go ahead and get to it. I want to just start with for Vivian, kind of where do you recommend for those that are novices? How do they just start, learning how to do this? Like, how would you recommend if they wanted to pick it up tomorrow, how to ultrasound the spine?
Yes, absolutely. That's a great question. Thank you, Jamie. Now, first of all, of course, you're not going to pick your very first patient with a BMI of 58. You want to scan straight off, not a too small patient, because then you may lose tissue contact. So just right, BMI of 25 is actually a nice person to start, and just get used to holding the probe and, applying the pressure, making sure you have the adjustment, you're familiar with setting up your ultrasound setting, and then go ahead and actually just put the probe on, using the systematic approach that I talked about. So your two probe orientation that you need to know, the parasagittal, paramedian sagittal view, and also the transverse view. So certainly, learn to identify the midline and mark out the levels. That would be a great way to start off. And then once you know, once you learn the pattern recognition and your anatomy, then, the more difficult spine sonoanatomy will come. Yeah.
Okay, great, thank you.
Thank you.
There's a question about the patient positioning, whether position lateral or sitting for the epidural, whether it can be easier to do some of the scanning on a difficult, especially thoracic epidural when they're lateral. Dr. Peacock, why don't you take that one?
Yeah, totally. We do, I always joke that at my site, we do maximally invasive surgery because we do a lot of big sarcomas. So in Toronto, we do actually a large number of thoracic epidurals at my site. I think honestly, at the end of the day, it's whatever you're the most comfortable with. The old guys who taught me a lot, they used to all do them in sitting with the patient in lateral, and that's where they had the most success. I think trainees now are just used to having the patient sit up to position them and to open up the spaces, especially for the lumbar epidural. So really at the end of the day, I think it is whatever you are the most comfortable, and that is where your feel is. Personally, for me, I do like having patients sit up because you can actually get the flexion, especially for the lumbar spine. It really opens it up. For the thoracic spine, it's a tighter space, and that's the whole point of the thoracic spine, is to not have a lot of mobility in it because it's protecting very important structures. So you don't necessarily always get that same opening up of the space, but it also allows me to do real-time ultrasound. Like a few times I've had to do it for thoracic epidurals and cases where we really need it for respiratory cripples. And I just find that when you're in lateral, it's not as easy to maneuver the needle versus in sitting, I actually have just more control in terms of doing it. That being said, our ESPs, now we're doing most of our ESPs and prone, because the patient's lying down, you can get on both sides, you can rest your hand, and you're not needing that space to be opened up. So I guess it depends on the context of what you're doing and the specific technique.
Yeah, I may add that sometimes you just don't have a choice. For example, the fractured hips. You have to do lateral. I find lateral a little bit more challenging. So if you are just going to start learning to scan the spine and just learning the pattern, then I think, with the patient sitting up if they can. And as Sharon said, you can open up the space really nicely, especially for the lumbar spine.
And for thoracic epidurals, which often could be more challenging just based on landmark and our technique, do you routinely grab the ultrasound for thoracic epidurals, especially high thoracic epidurals, where it is often more challenging just based on landmark anatomy?
So I always have a low threshold. If I struggle more than once or twice, I just grab the ultrasound. And it's funny because when Sanjib was speaking earlier, he's like, by the time I get the ultrasound, I've already done. But usually after I've done my first pass, if I've struggled, I'm telling someone to bring me the ultrasound. I keep going, but then it comes when I need it. So yeah, for the thoracic epidural, I often I look, is it going to be easy? Probably. Is there someone who's morbidly obese and I really am trying to focus on the correct level? Then I will be a bit more particular about how I actually plan out the epidural. For the most part though, I give myself the first go, and then if it's a challenge or if it's just not going in smoothly, the definition of insanity is doing the same thing over and expecting a different outcome. So then usually I start adding other things to help me be successful, because it's also for the patient's comfort. They don't want you standing there jabbing them in the back for 20 minutes.
Another thing is I find, there may be some, scoliosis and things like that. So you can actually pick that up using the ultrasound, and also the depth. You can actually, just estimate the depth to the posterior complex. Sometimes, you may want to, just grab your ultrasound and actually just do a quick scan.
Thank you. And Sanjib, a question about paravertebral catheters. Do you routinely use them for cases such as mastectomies or with tissue expanders? And if so, what do you dose them with, and do you send patients home with paravertebral catheters?
Yeah. Okay. First part, for the breast, we don't do paravertebral for our breast. We do pecs, but we do paravertebral catheters, a lot of them, for our rib fractures. We have a level 1 trauma, and we do have a lot of group of people doing, the first option is If it's unilateral, we go paravertebral, bilateral, epidural. If not, they're on anticoagulation, there's some contraindication, we do ESP, serratus anterior, other stuff. So that's the way we approach our rib fracture patients. I think we are starting a ERAS protocol where the paravertebral is going to be the part of our breast surgery. It is very difficult to put a catheter from when in the breast case when they are just here for some and they're trying to go home next day. So we do not send them in paravertebral with the going home because I don't think there is enough data or literature on the paravertebral infusion, how much the intake, ropivac and concentration last and all that features. So because of the safety concern, we do not send them home yet. But whenever they are in hospital, we do run them. But we run them basically like PIB, program intermittent boluses, instead of continuous catheters.
And Sharon, what about as far as I find that like a lot of my patients, they look that they would be perfectly normal back, often on OB, and maybe don't palpate things because they're not quite, maybe slightly overweight. And then I find I'm struggling, and then I finally get the ultrasound, and midline is several centimeters from where I thought it was. I mean, I just feel like it's so much more prevalent than we think, and why we struggle so much.
Yeah, no, I think you're totally hitting the nail on the head. And that's why often when I'm struggling sometimes, I think we have a lot of self-doubt. Sometimes we think I'm doing something wrong. Something is with me. And sometimes it's the patient. It's not that they're doing anything wrong, but that you just, like that OB patient I showed you the picture of, she was so thin. You thought you could see where her spinous process was, and it was actually her facet joints. So she was so rotated that her facet joints looked like the spinous process, and you couldn't actually see the spinous process. So I think, to everybody's point, like getting very skilled at using the ultrasound, then you are fast, you're efficient with it, and you also then have like spent a lot of time thinking about the anatomy, because I think that's the other thing that we haven't really explicitly said that, but we've all thought about the spinal anatomy to like such minutia, and then we revisit it and then we revisit it. So I think that it's then saying, okay, there's something weird that's here, and having a low threshold to just use the ultrasound, because you'll save yourself time, you'll save yourself a headache. You get cognitively frustrated sometimes, and it takes one layer out that you have a bit more true information to be successful.
And Sanjib, you talked a lot, we talked about paravertebrals today, and obviously you've done a lot of work with ESPs, and oftentimes, think of, a lot of people are like, ESP is the replacement paravertebrals, we don't need them anymore. And also a lot of people often think about, even respect to epidural, sometimes why not just do bilateral ESP catheters, which could be a good alternative in cases of anticoagulation. But are we getting too far away, with these new, fancy fascial plane blocks, and away from our just traditional neuraxial and paravertebral?
That's a $1 million question. Believe me, I'll tell you this. I am a full supporter of epidural. We do quite a bit of epidural for our upper abdominal and midline gastro cases. But, as anesthesia, as much as we can say, we are very driven by the surgery, the surgeons, right? And now the whole surgical focus in US is get them out of the hospital as soon as possible, get it out, and that's the way it is going. And with that, with epidural, we really had a trouble that whom to do epidural and whom not to do epidural, right? So we actually came into an agreement with our surgeon recently that if your patient stays more than 3 days, I'm going to do an epidural. If you are going to stay less than 3 days, okay, we can think of some other fascial plane blocks, right? So I think that is another totally different topics we can discuss for 1 hour, whom to go and what to do and what not to do. I think this is beyond the capacity of this discussion. Coming to your point, whether bilateral ESP is as effective as epidural, no, not at all. I being ESP myself, I would say they are not equal. But when you are not doing anything, I think ESP is providing something than nothing. That's how I look at it, right? If you are not doing any local anesthetics or any regional anesthetic procedure, I think you are giving an ESP in form of local anesthesia and delivering. That was why, interestingly, I put those last article on the anatomy article which came in the RAPM last year, right? They're fantastic article. They actually showed us there is more to learn in the anatomy we don't know yet. We do not know the paravertebral or the paraspinal anatomy completely yet. We think that we know, but maybe we don't know yet. So that is why there is more variability in these plain blocks, because it is so much dependent on so many different factors. Patient factors, where you are putting the needle, where you are injecting, how much you are injecting, what volume are injecting, what pressures you are injecting. So in fact, in ASA this year, we are talking about myths and facts about the fascial plain blocks, and I am preparing some slides on that. And it is fun you are bringing up that issue that is ESP, bilateral ESP is same as epidural. I don't think they are equal, but I think I was asking a wrong question here. Are we answering if you look at the type of or amount of pain relief you get from the epidural, I don't think we'll ever get it with a bilateral ESP. But do we really need that of pain relief for every patient, for every case? Maybe not, right? So these are the two different questions. I think it has to be answered by us as a regional anesthesia enthusiast and moving forward.
All right, thank you. And both Sharon and Vivian, I think, and Sharon, you talked about it, kind of the real-time ultrasound, neuraxial placement. What is there, what role is that? I mean, obviously it's not for any of our beginners that are watching, and I personally don't really use that technique because it takes a lot of extra hands that aren't always there. But where do you think that is really useful?
So I started typing in the chat, but I'm glad that you're, gives me an opportunity to talk about it. So I think that it's really useful in the patient that you're trying at all cost to avoid a GA. So a few times that just come to mind where we had a severe rheumatoid arthritis. She'd had basically all of her joints replaced. She had underlying lung disease, unrestricted lung disease from it. And obviously she was anemic, high risk of needing blood transfusion. So for so many reasons, the Neuraxial was like the way to do it. But we planned everything out, but we couldn't achieve it just by the planning. So it's easier to do a single shot spinal by yourself in real time than it is to do an epidural because you need the loss of resistance. So I honestly often do it if I'm struggling. I usually don't struggle more than twice, where I'm just just bring me the ultrasound and I can just trace my needle, watch my needle, because sometimes you're just veering off a little bit midline and it keeps you on point. I actually used it last week. I was telling you I was in PEI helping out there in a community hospital, and I got called because it was a woman with likely bacterial meningitis and they couldn't get a lumbar puncture on her. So that's another, it was obviously I've done this enough times. This wasn't the time to practice, but where the stakes are high and you really need to be successful. And so I tried once, I was struggling, so I just did it in real time.
All right, thanks. And Vivian, as we in the last decade, ultrasounds have become so prevalent, and we use it for all sorts of different things. Again, my residents are using it all the time for A-lines. Do you see ultrasounds being a routine part of our, neuraxial procedures as opposed to more of a rescue in the future?
Yes, I think for the future, I think ultrasound definitely has a role in actually becoming a routine thing, because nowadays it's just a change in mentality, really. Every single time when I pull up the ultrasound machine, everybody kind of sighed and, oh my goodness, it's going to take so long. But I said, hey, time me. It's I get the midline, I get the level. It's 2 minutes done. Of course, I'll, with the Philips machine, I will turn that on first, as I'm wheeling it in. And so it doesn't take forever to start, to get boot up. And I find that it's very important to actually teach our residents to do the routine cases so that they, it's not just the very difficult ones. Oh, let me show you this Sonoanatomy, and they are looking at some bad TV, it looks like. So they need to get used to it. It almost needs to be incorporated in the curriculum, really. So I think ultrasound, and also, with everything, the lines, vascular access, neuraxial block. Not just real time, it's just neuraxial block, just a ultrasound assisted, and with our nerve block, obviously, and now with POCUS. Even the medical student, I think they need to be introduced the concept of ultrasound. I think we are in the 21st century. Yeah.
No, I agree. I think it's going to become, I think more and more it's going to become part of our, trainees curriculum, utilizing ultrasound for, a variety of things like you mentioned. So, and I think just the key to anyone out there who's, just learning about both neuraxial ultrasound and, paravertebral, all of the scanning is understanding this anatomy, which is what we really wanted to talk to you about and teach you about, and have our amazing faculty, give their experiences on how they do it. So I just urge you, next time you're out there gonna do some sort of neuraxial, go ahead and start scanning on those, more normal skinny patients and just practice, and then you can move on to the more challenging patients. But that is all we have for today. So I just wanted to thank our amazing panel of speakers for some great talks and great discussion, and all of you that are here tonight to listen to us and might be listening to the recording later. So on behalf of ASRA, I thank all of you. And please remember to mark your calendars for our next Hot Topics, which is on June 14th. And it's my patient has a persistent nerve injury and what to do in a court of law. We have some great speakers. It's going to be our lawyer, Andrew Warwick Esquire, and Dr. David Hardman, who's a expert witness that frequently is involved in peripheral nerve injury cases. And we're going to have a fun session. It's kind of a mock trial to kind of the do's and don'ts if you ever have a malpractice suit, and how to handle cases of peripheral nerve injury after blocks. So it'll be a fun session. So mark your calendars and make sure to sign up for that on the ASRA Hot Topics page. Again, thank you to our speakers. Thank you to all of you out there watching us tonight, and have a great evening. And we'll see you in June. Bye.
Thank you.
Bye.
Thank you so
Thanks, guys.
much. Bye.